good. All right. So thank you to the 175 plus of you who are here to take in this lecture. And most importantly, thank you to Dr. Hainline, who's incredibly busy at this time, to give your time to join us. For those of you who do not know Dr. Hainline,
to sports. So,
please, excuse me, please mute yourself.
In fact, I got another meeting here that's
Okay, guys. Have everybody mute.
that's going to be.
So Dr. Hainline is the Chief Medical Officer. He's a clinical professor of neurology at Indiana University of Medicine, as well as the NYU School of Medicine. Prior to joining the NCAA, he was actually the Chief Medical Officer of the United States Tennis Association, where he established himself as a leader and authority in sports medicine, and particularly around expanding health and safety standards. When the NCAA came looking for a Chief Medical Officer, there was really no better choice than Dr. Hainline to lead that effort. As you all know from the many lectures time he's given to AMSSM, Dr. Hainline has been responsible for expanding a number of initiatives to support major factors that impact athletes: mental health, overuse injury, drug and alcohol misuse, and sudden cardiac death. Now we're dealing in a new situation with the COVID and how that might impact resocialization. And so Dr. Hainline agreed to give a talk about that topic, guidelines to opening up America again, and specifically how we get back to sports. So thank you, Dr. Hainline.
Well, thanks, Ashwin. And maybe if you wouldn't mind backing up one slide.
Sure, absolutely. There we go.
And it's always a pleasure to be with AMSSM. If you don't know, the AMSSM is really crucial to who we are at the NCAA. I rely on its members all the time for input, and they're a very important part of how we're moving forward with COVID-19. There's a working group with AMSSM that represents all three divisions of the NCAA. So everything you all do and everything you stand for is critical to what we do at the NCAA. So before I get into this talk, I just wanted to take a little bit of time to share with you what we're doing on a day-to-day basis at the NCAA. So importantly, there's an external advisory panel. So that includes 7 individuals that are representatives in global health, public health, infectious disease. One member, Stephanie Chu, she's on the Committee on Competitive Safeguards and Medical Aspects of Sports and a member of AMSSM. And then another individual is actually a security expert for all of the professional events in this country, professional sporting events, and especially looking at security from a mass participation point of view. So that's one group. Internally, we also have a COVID action team, which is essentially the senior management team of the NCAA. And we meet daily, and we're really focused on right now, what are we going to do in the summer and in the fall? There's also a working group of the Committee on Competitive Safeguards that I'm going to talk about, as well as some other working groups. But a couple of weeks ago, this external advisory panel, we said, you know, let's put together a document about the core principles of resocialization of sport. And when we were in the draft stages of this document, and then the next slide, the White House actually came out with their guidelines for opening up America again. So I'm sure most of you have seen that. And when you look through that document, it really is very well done. And you know, the criteria that it outlines are a little different than some of the dialogue that's going on at the national and at the state level. But really going back to the criteria that are outlined in this document, we still believe that those are really good criteria for trying to resocialize sport. And so I'm going to walk through a few of those right now. The next slide. So one of the key things that is important as we try to open up society again, and you know, and then we might ask, why are we even trying to open up society? I mean, is it worth it right now? Isn't it too early? And I think whenever we ask that question, we're asking it at multiple levels. I think at a broad societal level, even across this world, we're at a point where we need to ask ourselves, how do we really maximize the number of lives saved? And as the data are coming in, one can ask, are we actually maximizing the number of lives saved by staying in a state of lockdown? And one of the consequences of that and of being in such a lockdown state is that right now there are about 250 million people on this planet who are at threat of imminent starvation. We know if we look at the emerging data, even from New York City, that the number of untreated strokes and myocardial infarctions, other types of infectious diseases, the ability to treat them has been severely hampered. But at the same time, we were at a raging amount of COVID cases. New York City had no surge capacity, and almost 100% of its beds were taking care of COVID-19 patients. And we know that of the first 5,100 in New York City, for those on a ventilator, 90% never came off of the ventilator. So that's a remarkable statistic when the average ventilator time in New York City is 3.4 days. So we're always looking at, so what are we doing in the community? How do we maximize the number of lives saved? And at some point it means really being in a lockdown, but at another point, it means looking at the public health and medical consequences of profound economic loss and other public health losses that are happening as a result of lockdown. So looking at these phasing criteria, when you start to open up, just from the point of view of COVID-19, you want to hopefully do so when symptoms of influenza and COVID-like symptoms are down, when the infection rate is down. So we can look at New York City right now, where I've been for the last couple of months, and the R value is at about 0.6. So you really want that R value, the rate of infection to be less than 1. And our infrastructure is starting to open up. We're actually starting to do elective procedures. So these are what we call the gating criteria. And we also believe that it would make sense for that to be applied to sport. And then one last point before I move on, we might ask, why are we even considering moving sport forward? Well, sport we might consider, and I certainly do, a core or essential activity of society. When you look at the benefit of sport, especially youth sport, getting that right, getting people physically active, physically engaged, even emotionally engaged, spiritually engaged, if you will, we need to also look at the societal benefit of sport, and if we are going to bring sport back, to do it in a manner that's safe. So what are some of the, yes, the next slide is good. So some of the really important aspects, and I'm going to keep re-emphasizing this, and I'll just really summarize this slide as 3 key points. One is that if we're going to bring sport back, we're going to have surveillance. And our country is not known for great surveillance. We don't do it from the point of view of testing. We don't have the infrastructure infrastructure in place from the point of view of syndromics. Screening and surveillance. We kind of shut down our flu surveillance in the summer. So that's going to have to be at a markedly magnified level to also enable contact tracing. Testing is going to have to be really ramped up, and I'm going to talk a little bit more about testing. And where we are today in testing is radically different than where we were a week ago, and it's markedly different than where we were on March 11th and 12th, when we made decisions to first eliminate fans from the Final Four, and then to eliminate the Final Four as well as all spring and winter championships. And back then we even had an ethical discussion. Could we have a really small Final Four? Let's just invite 4 teams, get them in a really enclosed environment. And back then we couldn't, from several points of view, but one was testing, because then testing was so prioritized that, for example, at Emory University, where we were thinking of working, only the very critically ill were being tested. Not even the ill could be tested because it was so prioritized. Test results took 72 hours. There was no way you could safely or ethically do even a small Final Four in those circumstances. Now the testing is in a much different place. And then the next slide. So importantly, in every aspect of opening up sport or society, ideally it's done in a phased-in approach, because as you begin to emerge, you want to make certain that the gating criteria remain fulfilled, so that you don't all of a sudden have a surge in infection, or that you don't all of a sudden have a healthcare infrastructure that can't really adapt to a surge capacity. And so those are the important things to be looking at. So the phasing is really important. And then the next slide. The one thing that is going to be the new normal, and that's, you know, and the new normal is, the bottom line is, it by all accounts that at least we can see, we're going to be with COVID-19 for some time. We talk about a vaccine, and we're all very hopeful for a vaccine. But you know, the closest relative that we know of this particular variant of coronavirus is the one that led to SARS. We don't have a vaccine for SARS. We don't have one for MERS. We don't have one for HIV/AIDS. So ideally, we will have one, but you can't keep society shut down waiting for a vaccine, because that's going to lead to other really public health consequences that are not acceptable. And so we have to learn, if you will, to cohabitate with this virus, and part of that is going to be markedly enhanced hygiene and the way we practice sports medicine. It's not going to be that people just come into the training room when they want. It's going to be very phased in. People are going to be wearing protective equipment. I think universal masking is probably going to be here to stay for some time. It certainly is well accepted in China and in other countries that have successfully dealt with this. And I think that's going to be part of the new norm, as well as how we really look at the gyms and so forth and shared equipment. And the other thing is that, you know, it used to be a badge of honor to show up when you weren't feeling well. Well, now that would be a badge of social irresponsibility if you do that. So the next slide. One of the things is, you know, we're thinking on a very regular daily basis, you know, how are we going to sort of develop some sort of a screening, if you will, and just a check-in system. And it's not going to be that people are going to be tested every day, but there's going to have to be some sort of way that you have a check, you know. So do you have everything in place in terms of your physical distancing, your mask? Have you taken your temperature, or is there a way? Do you know if you're ill? So all of these things are going to have to be done. And then the next slide. And essentially, we're going to be in this sort of space until either there's universal or really herd immunity, I should say, which means that the virus has really affected so many people in this population, mostly at the minimal symptom or almost asymptomatic level, that the herd immunity is developed, or that we have an effective vaccine, or that there really is an effective treatment to neutralize the effects of this virus. And that probably is going to take some time. And so the new normal is that we have to adapt, and we have to make certain that we're doing this properly. And then the next slide. And the other is, we have to understand that collegiate sports are very different from professional sports. So collegiate sports means that first and foremost you have students, and so the question is, what does that mean? Does it mean that they have a college sport team, an NCAA team, that it has to be back to normal on the college campus? And it doesn't mean that, because I don't think there will be any college campuses that are back to normal. Could it mean that maybe there aren't a very large number of people that are on the college campus, and that some of the large classes are being done virtually? It could mean that. Could it mean that athletics, that the only people that are on a campus, meaning there's no professors, there's no other students, there are only athletes? That model doesn't make sense for the NCAA. But other models where there are hybrids and different sorts of ways that students are returning and athletes being part of that, that does make some sense. And I think we also have to be thinking, so, you know, what even makes sense right now for schools to return? Should we be thinking about an earlier return or a later return? Because there are many models right now where some schools might be starting before, say, September 1, or maybe even in early August, and they'll have a compressed schedule, and when Thanksgiving break comes, that's it. That's the end of the first semester. And so the question is, would we be thinking of championships that way as well? So there's a lot of modeling going on like that. And then the next slide. So one of the things that I'm doing also is meeting with other chief medical officers of sports, like the NBA and the NFL, the NHL, Major League Baseball. In fact, I have several calls set up again for this week. We did have a meeting a little more than a week ago with Dr. Birx's office and the White House, and I can tell you that the majority of that meeting was centered around testing. And so the White House said, look, we're expanding testing. There's going to be enough tests to go around. But, you know, there's not going to be tests that are going to all of a sudden magically descend from some centralized place in the White House. And so one of the things that became clear is that as schools are opening up or conferences are thinking about opening up, that there should really be conference-wide decisions about how testing is going to happen and even how you're going to obtain the test, because it's not likely, like I said, that they're just going to somehow magically emerge. And so there's support on that, but it's, you know, that's a little different than it actually happening. And the other is really the very specific protocols of testing. And so I wish I had for you today sort of a magic protocol, and I don't, and that is being worked out. And when we talked about that with the White House and said, well, you know, you have a football player who tests positive, and Dr. Fauci really recently commented on this. Well, what happens, and what are some of the ways that we can go through that? And the White House essentially said, well, if the chief medical officers of sport can get together and come up with a creative scenario, that would be great to share with us so we can look at it as well. So no one really has that magic scenario, but you also can't really think about sports going forward that are like football unless there's a very, very regular, detailed, granular protocol that has to do with testing. Some of the initial ideas are that people are screened or tested when they first arrive. Another is that before major games, that for the intense contact collision sports, that all the essential personnel would be tested. That's just as good as for that game goes. When someone does test positive, are there scenarios where the individual who tests positive or who becomes newly infected is isolated for 14 days? But then what do you do for all of those close contacts? Does everyone need to be isolated for 14 days? Well, if that's the case, and that may be the case, that essentially means shutting down the sport. Or are there ways that one can do testing 1, 3, and 5 days, and that there's a shortened quarantine? So this is what's actively being explored right now. And the other thing we don't have the answers to, if there are some that have a high IgG titer, does that mean that they're actually immune? So hopefully we'll get these data answered, or these questions answered over the next month. And then the next slide. So as we think about coming back to collegiate sport, it really does make sense that you bring it back in small segments. One is because it just makes sense that you don't want to bring everyone back all at once, because you could have a marked spike in infection. But even as we think about it from a practical point of view, a phase 1 is sort of a way where you're saying, well, yeah, you know, we got phase 1 down. Everyone understood what they needed to do. We had all the infrastructure for sanitization in place. People were following what they should do. So it's also a way of making certain that you're testing out your local protocols, you can do it properly. And really in phase 1, you're not talking about contact, you're talking about really sort of small groups of individuals who are beginning to engage in exercise. And then the next slide. And in keeping with the federal guidelines and even applying them to sport, you start opening up in phase 2. We don't imagine in phase 2 that you actually are in a contact collision sort of scenario. We even imagine that people are still wearing masks, that you know, this is, you're still trying to increase your socialization, and you want to make sure that it's done properly. And then the next slide. And then the question is, in phase 3, assuming that you've met all these gating criteria, can you start engaging in contact? So in basketball practice, because there is summer basketball practice, or in football practice, soccer. You know, it's a little different playing soccer and football than it is running cross country. And so it looks a little differently in all of these sports. But this is where we really have to understand what really is happening with our teams and what's happening on the campus. The one thing that is not that well worked out, and it's just never been something that we've done very well in our country from a public health point of view, and that's really surveillance testing or surveillance screening. And do we have to test everyone on campus all the time, or is there a way that we can use mathematical modeling and working with good epidemiology so that we understand the movement of this virus and we can act accordingly. All of this really still being worked out. And then the next slide. So this all went through extensive membership review. For those of you who don't know all the acronyms, so in Division 1, the Strategic Vision and Planning Committee, and then there's the Division 1 Council, the Division Presidential Forum, the Board of Directors, Football Oversight Committee, the Competition Oversight Committee, Men's and Women's Basketball Oversight Committee, and then the conference commissioners, and then in D2 and D3, working with their management and President's Council, and then membership-wide, working with the Board of Governors, and I don't think it's showing on this slide, but also the Committee on Competitive Safeguards and Medical Aspects of Sport. And then the next slide. And then this is a really important group that has been put in place, the COVID-19 Playing and Practice Seasons Working Group. And this is a group of staff individuals. So remember, the NCAA is the membership, but it's the full-time professional staff that is trying to serve the membership and help them make informed decisions. So this is a group that is really linked with Football Oversight Committee, a membership committee, Competition Oversight Committee, Men's and Women's Basketball Oversight Committee, and Competitive Safeguards, all membership committees. But the group really is not just health and safety individuals, but also individuals who look at all the legislative aspects of sport, or all of the regulations, the academic and membership affairs aspects of sport. And so we're really looking at, well, what does it mean? Could we have possibly a condensed season? Could it be that there's only going to be 6 weeks of a competitive season before championships? Could it be that we're going to shift what the pre-participation physical exam is? Well, actually, Competitive Safeguards, this subcommittee, ruled on that, and they said, well, no, you can't shift that. You need to have an in-person and still a detailed physical exam. Can it mean that we can shift what we do virtually? Well, Competitive Safeguards recently formed an opinion on that and said, you know, if the membership can help assure the responsibility of making certain that virtual workouts can happen, well, then maybe they can happen. And, you know, are there ways that we can really reimagine you know, if you will, organized team activities in the summer, assuming that people are on campus on the summer? So the Committee on Competitive Safeguards recently ruled on that and said, well, yes, we can imagine activities like that taking place. So there's going to be a lot of flexibility and nimbleness in terms of trying to understand how we can really work with possibly a condensed season. One thing that will not happen is the NCAA is not going to say, okay, this is the date that everything starts, because that's not the NCAA's decision. So that really happens at the state and local level. They have to decide what really is allowed and not allowed, and then at the individual campus level. And so there may be some competitive inequity, if you will, and that some places may be starting earlier than others, but that's just what this situation is presenting to us. And then the next slide. And so, yeah, this is the purpose of this working group. So, you know, there were even scenarios like, and so you may know that some schools are saying, you know, maybe we should be opening up a little bit early so that we can finish our semester by Thanksgiving. And, you know, within that scenario and that way of thinking, does it make sense to have the championships before Thanksgiving? Well, we don't control the college football playoffs. The NCAA doesn't control that. And it doesn't seem likely that there would be a condensed football season. But for the other fall sports, that is one scenario that is being played out, because what might be happening around Thanksgiving time when everyone goes home and then comes back after that, well, you know, that's when there may be another great wave of this infection. You know, there could be one in August too. So all of these plans could, you know, have to change. And so that's part of the need for great flexibility. And then the next slide. And so our timeline, this is actually an old slide. There's going to be we already put out a frequently asked questions document after we put out this core principles document. And there's another one that's going to be coming out shortly that's going to really be talking about issues of testing. That's going to be discussing the core issues of sanitization and really getting at a more granular level. And just, you know, to keep in mind that what we're putting out are considerations. It's not policy, and you know, how can you even really put out policy or endorse documents when we're all really learning day by day? So that's at the level we are. And then the next slide. And that's it. So I just wanted to have an opportunity where I appreciate having the opportunity to give a little bit of an overview of where we are. I can tell you even where my thoughts are and my colleagues' thoughts are today is different than it was yesterday. And so we're really all in this together. And again, just expressing my gratitude for AMSSM and especially for the working group that we have with AMSSM that is providing a lot of guidance to us. So thanks for this opportunity.
Well, thank you, Brian. That was really great, fantastic outline and sort of philosophy behind that outline and understanding how we might be needing to move forward. I want to open up the chat for questions. If you can text any questions in, that would be great. I'll read them and then Brian can tackle those. So if you have questions, so we have one. This is from AJ Monceau. Thoughts on the feasibility of implementing recommendations outside of FBS? It seems that FCS, D2, and D3 schools would have major issues implementing some of these recommendations. Thoughts around that, Brian?
No, look, I think that's a great point. So and that's why we really have to understand a lot of the modeling. So we're working on with other experts on how to really model this properly, because at the level of testing everyone before a game, we're doing very frequent testing. I mean, you're talking easily about $1,000 or more per football player, as an example. So, you know, that's the cost of a Vicus helmet, which is no longer in business. And does one need to have 4 or 5 football helmets per player? And so we're all redoing how we're thinking about this. But that's why I think the surveillance testing, and which is still being worked out, will be important. And so honestly, I don't have those answers, and it may be that if we can't get the answers, that one possibility is that it might not be safe to play football either. And so that's the reality we're dealing with. And it would be a shame that football could only be played, for example, at an FBS level and not other levels. And so it's a great question, one for which I don't have the answer yet.
Thank you. This is from Jolie Holshin, talking a little bit about the challenges around testing, seeing that routine PCR takes 1 to 2 days to turn around, but the more rapid PCR tests tend to have the point of care testing is only 50 to 75% sensitive and not necessarily clearly excluding disease. And can you comment on how the NCAA will support testing and procure testing, as well as oversee contact tracing and any considerations around antibody test use?
Yeah, so again, don't have the answers now. There's no way the NCAA can oversee contact tracing. I mean, that's simply an impossibility, and actually it would not even be a good thing. So what really has to, I mean, contact tracing in the ideal world, what the CDC has 300,000 or 400,000 individuals that are out, and we're doing this like a country with great public health infrastructure. Not where we're going to get there. Contact tracing really is in the purview of the local public health officials, and so the member school is really bound to follow that. There is actually, interestingly, a Johns Hopkins course where people can learn to become contact tracers, and one thing is, should that be something that universities should be thinking about? You know, with the testing, so the very rapid point of care testing, it's true. I mean, the sensitivities range anywhere from 50 to 75%. So you're missing potentially 50 to 75% of individuals. That's not acceptable. You know, I looked at some data actually just yesterday using a new serology test that looks at both IgG and IgM. And I was actually a little surprised that the IgM sensitivity for detecting disease, if this can be validated, the sensitivity was fairly high. It was over 90%. You know, could we be thinking about if that really evolved in a hopeful manner, that becomes a screen, and then there's a verification with a PCR test? You know, the salivary test that came out of Rutgers, the problem with that is that the capacity issue is there's no way they're going to have the capacity even in a month from now. So all of these, you know, as we stand right now, could we roll it out right now with what we have? The answer is no. And so and these are the issues even with Major League Baseball and with their rollout. I mean, these are the struggles. So the White House has said we want sports so badly, we're going to make sure the tests are there, but it's not there right now. That's all. Yeah, that's all I can say. But these are some of the trends that we're tracking on.
Brian, there was a question about screening athletes or students before returning to campus versus after returning to campus. Just thought that was an interesting question, so I wanted to put that forth.
Yeah, and so it's even been broken down even further. You know, the screening of people who come by car versus those who travel by plane. It's complex. I don't know the answer. You know, because the screening right before travel. So ideally, you wouldn't want someone coming to campus if they screen positive, but even after travel, they might again. And so at least most of the models I've looked at campus-wide, they're screening upon arrival, and those that are positive are quarantined. Is that the best? I'm not sure. You know, the travel's tricky. You know, Emirates Airline, they actually do a test before anyone's allowed on the plane, but the other airlines aren't there. So it seems like where people are moving to right now is screening upon arrival.
Another interesting question that I thought was asked from Jay Clugston was, based on the core principles document, should athletes who are vulnerable, those, for example, with hypertension, asthma, or diabetes, not return to campus until phase 3? Or if they return earlier, what types of restrictions might be considered or thought about for those vulnerable athletes?
Yeah, and I think we take that and move it even one step further than we did with sickle cell. And so how do you really address those athletes? And that's one of the sort of ethical and medical core principles that we haven't landed firmly on, but it's first and foremost, and it's not just the athletes, it's the coaches too, and the other essential personnel. So I think we have to be really, really careful about that, and at least in my view, and this hasn't been articulated outside of what I'm saying here right now, it's hard to really see that the vulnerable would even be that they would be engaged in phase 1 or even phase 2. I think we have to make certain we have all of the protective mechanisms in place before we're even bringing others in, which are the more vulnerable. That's just my personal feeling as I'm thinking about it right now.
Absolutely. So to that end, what about students coming from higher risk areas, or international students, for example, might be coming from Italy or a place where there's been more widespread disease? Thoughts about quarantine or sort of separation from the rest of the student athlete body coming back into campus?
Yeah, so that's another interesting question. Right now, actually, I would probably rather be hanging around someone from Italy or New York City than a lot of other places in this country. New York City, the R value is 0.6. Italy, it's somewhere around there as well. And versus, it's many areas of our country where we have really no idea what the R value is. We have no idea from a surveillance point of view what really is the infection rate around there. So I think that made sense when we were thinking about this a month or so ago. I'm not sure how much sense it makes right now, as we've come to understand this more, and we've really come to understand really our lack of surveillance screening. So I think from that point of view, there's the assumption that everyone who comes in, we have to ascertain where they are when they arrive.
There was also an interesting question about the issues related to travel and how, some teams traveling across regions, whether there's any thought to dealing or managing that type of travel to reduce risk.
So I'll tell you, there's a lot of discussion about that. And these are decisions that are really made at the conference level. So again, understanding competition, that's not championships. So the NCAA oversees championships. We don't oversee the conference competitions or the school-to-school competitions. But I can just tell you what is happening is that the conferences are really rethinking their travel. They're really rethinking playing even outside of conferences. And I have a strong feeling that for 2 points of view, you're going to see a lot of travel happening more by van or a lot more restricted kind of travel, both for financial reasons, and even from an infection control point of view. So I think the travel that used to happen, I strongly suspect we're not going to be seeing that. And you're going to see accommodations being made to allow for much less competition and for the conferences to be adaptable from that point of view.
Great. I'm going to field another question or two, and then I think we'll wrap it up. Question was also around considerations for postponing seasons. For example, running football in the spring instead of the fall, depending on the circumstance at that time.
Yeah, so we actually had that discussion this morning, and we consider that the last option. Just logistically, it's kind of a nightmare.
Yeah.
And you know, and then you think about the winter sports and the spring sports. So and when you look at most schools, you know, the reason why say field hockey or yeah, soccer and lacrosse are played in different seasons, well, they share fields. And so it's really logistically, it would be exceptionally difficult to do. And again, the football that the NCAA controls is the FCS championship, but not the college football playoff. So that decision is made by that group. And right now they're planning on holding that, you know, in January when it was originally scheduled.
Great. Yeah, I'm sort of looking around. I think a lot of the questions have been answered. I'm sure that there's many other great questions, but I wanted to respect your time. Brian, I really appreciate you taking the time. There were about 245 people on this, so that was a great opportunity to come together and understand together some of the steps that are being taken and how to reflect upon those steps. And I really appreciate you taking the time to answer our questions as well.
No, I appreciate the opportunity, Aswin, and for those of you who have, please write me any of your thoughtful ideas or criticisms, because, you know, look, we're really all in this together, and I'm gathering as much information as I can, but there's a lot of people out there who have given considerable thought to this, and there's a lot of people out there who are a lot smarter than I am. So any help in putting this all together, it's very much appreciated.
Appreciate it. Thank you, Brian. And thanks for everybody who is on the Zoom. So have a good day. Stay safe, everybody. And we'll catch up soon. Take care.
All right, thanks. Bye.
Bye.